Hello, today's topic is spontaneous bacterial peritonitis. This is the ICO book by Paul L. Merino, 5th edition. This is chapter 39. Let's start our discussion. About one third of the patient with decompensated cirrhosis have a bacterial infection, and the most common infection is spontaneous bacterial peritonitis (SBP). This, which is an infection of the ascitic fluid without a primary site of infection in the abdomen. The source of the infection is the translocation of enteric pathogen across the bowel mucosa. Spontaneous bacterial peritonitis occurs only in patients with cirrhosis and ascites, because cirrhosis impairs the normal function of liver to eradicate the microbes that translocate across the bowel wall. About 50% of cases, spontaneous bacterial peritonitis are community acquired, while 25% are classified as healthcare associated. That is, the patient had contact with healthcare facility within 90 days, and remaining 25% are nosocomial. A single organism is the isolate in most cases of SBP, and the most common isolate are gram-negative organisms, especially E. coli and Klebsiella pneumoniae, Escherichia coli, and Klebsiella pneumoniae, with gram-positive organism, usually Staphylococci and Enterococci. A distant second single organism is isolated in most cases of SBP, and the most common isolates are gram-negative organism, especially E. coli and Klebsiella, with gram-negative positive organism, usually Staph and Enterococci. A distant second, Enterococci is gram positive Enterococci. Resistant organisms are isolated in 35% of cases worldwide, but the prevalence is much lower, 16% in United States. Resistant organisms are isolated in 35% of cases worldwide, but prevalence is much lower in USA. Now, antibiotic therapy. Diagnosis: SBP can present with fever, abdominal pain, and rebound tenderness, but it is asymptomatic in one third of cases. A paracentesis is required for the diagnosis, and an absolute neutrophil count more than 250 per cubic millimeter in ascitic fluid secures the diagnosis regardless of the culture result. A paracentesis is required for the diagnosis, and an absolute neutrophil count more than 250 per cubic millimeter in ascitic fluid secures the diagnosis regardless of culture result. So absolute neutrophil count above 250 is diagnostic. An organism is isolated in 60% of cases, A positive culture without required neutrophil count in ascitic fluid is not sufficient for the diagnosis of SBP. So if the culture is positive but neutrophil count is not above 250 per cubic millimeter, then diagnosis is not confirmed. In this situation, a repeat paracentesis is wise. SBP should be suspected in all patients with decompensated cirrhosis and liver failure who are admitted to the ICU or who experience a sudden deterioration while in the hospital. SBP should be suspected in all patients with decompensated cirrhosis and liver failure who are admitted to the ICU. SBP should be suspected in all patients with decompensated cirrhosis and liver failure who are admitted to the ICU and who experience a sudden deterioration while in the hospital. A paracentesis should be performed when SBP is suspected and a fluid sent for cell count and culture. For optimal culture result, ascitic fluid should be added to some blood culture bottles, aerobic and anaerobic, at bedside. For optimal culture, ascitic fluid should be added to blood culture bottles, aerobic or anaerobic, at bedside. So diagnosis needs a clinical feature of fever, abdominal pain and rebound tenderness. But in asymptomatic cases are 1/3. Paracentesis is required for diagnosis and absolute neutrophil count should be more than 250. Culture is not required in that case, but a positive culture without a sufficient neutrophil count is not diagnostic. And it should be suspected in all patients with decompensated cirrhosis and liver failure who are admitted to ICU and who experience a sudden deterioration while in the hospital. A paracentesis should be performed then, and fluid should be sent for cell count and culture. Antibiotic therapy. Antibiotic therapy is started in all cases when absolute neutrophil count is more than 250 per cubic millimeter before the culture results are available. The choice of antibiotic is determined by the place of origin of the infection and the prevalence of resistant organism in your ICU. This is shown in the algorithm of figure 39.4, which can be summarized as follows. Resistant organisms are unlikely in the community acquired SBPs, and third generation cephalosporin are generally recommended. Resistant organisms are unlikely in the community acquired SBPs. So, if the SBP is community acquired, we should not think about resistant organism. Then a third generation cephalosporin like ceftriaxone or cefotaxime is generally recommended. Resistant organisms are typically isolated in nosocomial cases of SBP and less frequently in healthcare associated infections. Resistant organisms are typically isolated in nosocomial cases of SBPs and less frequently in healthcare associated infections. Less frequently healthcare associated infection. A nosocomial infection is one that appears after 48 hours in the hospital, while a healthcare associated infection is one that appears within 48 hours after admission in a patient who have had contact with healthcare facility in the last 90 days. So healthcare associated infection means patient have a contact with healthcare facility within 90 days and Infection appeared within 48 hours of admission. But nosocomial infection is that appears after 48 hours of hospital admission. So, resistant organisms are typically isolated in nosocomial cases and less frequent in healthcare associated infection. If a resistant infection is possible, a carbapenem like meropenem 1 gram every 8 hours is recommended, with a vancomycin added if methicillin resistant Staphylococcus aureus is a potential offender, or daptomycin if vancomycin resistant enterococci are suspected. So meropenem and vancomycin, or daptomycin if vancomycin resistant enterococci. And if resistant organism is unlikely, a broad spectrum coverage with enteric pathogen with piperacillin and tazobactam is sufficient. Antibiotics should be continued for at least 7 days, regardless of the culture result. The response to antibiotics can be assessed by a repeat and paracentesis after 48 hours. That is, a favorable response is defined by more than 25% decrease in neutrophil count. More than 25% decrease in neutrophil count. Here is a flow chart or algorithm of empiric antibiotic treatment in spontaneous bacterial peritonitis. If it is community acquired third generation cephalosporin like cefotaxime or ceftriaxone, if it is healthcare associated or nosocomial, and prevalence of resistant organism is high, then carbapenem plus minus vancomycin or daptomycin, and if resistant organism is less prevalent, then piperacillin and tazobactam is enough. So this is all about spontaneous bacterial peritonitis. We learned about the antibiotic regimen and antibiotic therapy, diagnosis of the case and when to suspect. Thank you very much for your patience, and we are grateful to Paul L. Merino for the ICU book 5th edition.